Every week, there are dozens of new pulmonary and critical care papers. Most add another piece to the puzzle. A few change the picture entirely. This week, we'll cover one paper that may redefine acute exacerbations in fibrotic interstitial lung disease, another that puts a popular ICU recovery strategy to the test, and a resuscitation study that could reignite the Lidocaine versus Amiodarone debate. Welcome to This Week in Pulmonary and Critical Care Medicine, your clinical intelligence briefing on the latest research shaping pulmonary, critical care, and sleep medicine. Let's dive in. Let's begin with what is arguably the most influential pulmonary publication of the week. If you've ever cared for a patient with fibrotic interstitial lung disease who suddenly develops severe hypoxemia, you've probably faced a familiar dilemma. Is this a true acute exacerbation, or is another process responsible for the deterioration? For years, that question has been surprisingly difficult to answer. The definitions we've relied on were developed primarily for idiopathic pulmonary fibrosis and were never intended to encompass the rapidly expanding spectrum of fibrotic ILDs we see today. As a result, clinicians have used different criteria, researchers have enrolled different patient populations, and comparing studies has become increasingly challenging. To address this, an international panel of experts has published an updated consensus report proposing a unified framework for acute exacerbation of fibrotic interstitial lung disease. The goal isn't simply to change terminology, it's to ensure we're all describing the same clinical entity. One of the report's most important contributions is distinguishing between acute respiratory worsening, or ARW, and acute exacerbation. Think of acute respiratory worsening as the broad umbrella. It includes any sudden deterioration in a patient with fibrotic ILD, whether it's caused by pneumonia, pulmonary edema, pulmonary embolism, bronchitis, or another identifiable process. An acute exacerbation, however, is much more specific. It's characterized by acute respiratory deterioration accompanied by new diffuse alveolar injury, typically diffuse alveolar damage, with or without organizing pneumonia, occurring in a patient with established or even newly diagnosed fibrotic ILD. Importantly, the presence of an infection no longer automatically excludes the diagnosis. A patient may have severe pneumonia that actually triggers a true acute exacerbation, meaning both conditions can coexist. Why is this distinction so important? Because not every patient who suddenly deteriorates has the same underlying disease process. When we group biologically different conditions together under the same diagnosis, it becomes much harder to identify treatments that truly work. The authors argue that this lack of standardized definitions has been one of the major obstacles to progress in the field. The report also reviews the current evidence surrounding risk factors, imaging, pathology, prognosis, and management. Unfortunately, one message remains unchanged. Acute exacerbations continue to carry an extremely poor prognosis, with high short-term mortality despite advances in supportive care. While corticosteroids remain widely used, the evidence supporting their benefit is still limited, and no pharmacologic therapy has consistently been shown to improve outcomes. Management, therefore, continues to focus on excluding reversible causes, optimizing supportive care, and individualizing treatment decisions based on the clinical scenario. Perhaps the most forward-looking section of the report focuses on research. The authors emphasize that future clinical trials must use standardized definitions and better patient phenotyping. Only by studying comparable patient populations can we hope to develop effective therapies for this devastating condition. Sometimes the most important papers don't introduce a new therapy, they redefine the problem. That's exactly what this international working group has done. By establishing a clearer framework for acute respiratory worsening and acute exacerbation in fibrotic ILD, they've provided clinicians and researchers with a common language that should improve patient classification, strengthen future clinical trials, and ultimately bring us closer to effective treatments for one of the most challenging complications of fibrotic lung disease. For years, we've believed that if we could get critically ill patients moving earlier and provide more protein, we could reduce muscle wasting and improve recovery after the ICU. It makes intuitive sense. Critical illness is profoundly catabolic. Patients can lose significant muscle mass within the first week of mechanical ventilation, and ICU-acquired weakness is associated with prolonged ventilation, delayed recovery, and poorer long-term quality of life. But what happens when we put that theory to the test? That's exactly what the NEXIS trial set out to answer. Investigators randomized mechanically ventilated patients with acute respiratory failure to one of two strategies. The intervention group received early in-bed cycling combined with intravenous amino acid supplementation to increase protein delivery, while the control group received usual ICU care. The primary goal was straightforward: improve physical function after critical illness. The intervention worked exactly as planned, at least from a physiologic standpoint. Patients in the treatment arm received substantially more protein and were able to participate in structured early exercise. If protein deficiency and immobility were the main drivers of ICU-acquired weakness, this strategy should have translated into better recovery. But it didn't. The study found no significant improvement in the primary functional outcome, nor were there meaningful differences in several important secondary outcomes, including duration of mechanical ventilation, ICU length of stay, or survival. In other words, despite successfully delivering the intervention, patients didn't recover any better than those receiving standard care. So why is this study important? Because it reminds us that correcting a biologic abnormality doesn't necessarily improve clinical outcomes. Critical illness is far more complex than muscle loss alone. Inflammation, mitochondrial dysfunction, hormonal changes, neuropathy, and prolonged immobilization all contribute to weakness, and simply increasing protein intake may not be enough to overcome these processes. The investigators also demonstrated that this combined strategy was feasible and generally safe, which is valuable information for future studies. Rather than closing the door on ICU rehabilitation, the trial helps narrow the search. Perhaps the timing needs to change. Perhaps different patient populations benefit more than others. Or perhaps nutrition and exercise need to be paired with other interventions to meaningfully alter recovery. This is an important reminder that negative trials are not failed trials. They often provide just as much insight as positive ones by challenging assumptions that have become routine in clinical practice. Sometimes the most important studies aren't the ones that prove an intervention works. They're the ones that tell us it doesn't. The NEXIS trial is a perfect example. It rigorously tested a strategy many clinicians expected to succeed and found no meaningful clinical benefit. While early mobilization and thoughtful nutritional support remain cornerstones of good ICU care, this study suggests that simply adding intensive in-bed cycling and intravenous amino acids is unlikely to be the breakthrough we've been looking for in preventing ICU-acquired weakness. Let's finish with a paper that revisits one of the longest-running questions in cardiac arrest management. When a patient remains in refractory ventricular fibrillation or pulseless ventricular tachycardia despite multiple defibrillation attempts, most of us instinctively reach for amiodarone. It's the antiarrhythmic recommended in current resuscitation guidelines and has become the default choice in many emergency departments and intensive care units. But has it truly earned that position? This new study used a target trial emulation, an increasingly popular research method designed to mimic the conditions of a randomized controlled trial using large observational datasets. Instead of simply comparing patients who happen to receive different medications, the investigators carefully adjusted for differences between groups to estimate what might have happened if patients had actually been randomized to receive either lidocaine or amiodarone during out-of-hospital cardiac arrest with a shockable rhythm. The results were intriguing. After adjusting for potential confounders, there was no statistically significant difference between lidocaine and amiodarone in the primary outcome of survival. Neurologic outcomes were also similar between the two groups. Although lidocaine showed a numerical trend toward improved survival in some analyses, the confidence intervals crossed 1, meaning the findings were not statistically conclusive. So what does this mean for clinical practice? First, it reinforces something we've known for years. Neither antiarrhythmic is a magic bullet. The interventions that have the greatest impact on survival remain early recognition, high-quality CPR, rapid defibrillation, minimizing interruptions in chest compressions, and prompt treatment of reversible causes. Antiarrhythmic drugs play a supporting role, not the starring role, in successful resuscitation. Second, the study raises an important question about whether we've been too quick to assume amiodarone is superior. Current guidelines favor amiodarone largely because of historical trials showing improved rates of return of spontaneous circulation and hospital admission. But convincing improvements in survival to discharge or neurologically intact survival have always been difficult to demonstrate. This analysis suggests lidocaine may perform just as well, at least in contemporary practice. Of course, it's important to remember that this is not a randomized clinical trial. Even sophisticated statistical methods cannot completely eliminate residual confounding, and the findings should be viewed as hypothesis-generating rather than practice-changing. The study doesn't tell us to abandon amiodarone, but it certainly reminds us that the evidence separating these two drugs is much weaker than many clinicians realize. Sometimes the most valuable studies don't give us a new answer. They remind us to question an old one. That's the real contribution of this paper. It challenges the assumption that amiodarone is clearly superior to lidocaine and highlights the need for contemporary randomized trials to settle the debate. Until then, the fundamentals of excellent resuscitation remain far more important than which antiarrhythmic happens to be in the syringe. The best clinicians aren't the ones who have all the answers. They're the ones who keep asking better questions. This week's papers reminded us why. One challenged how we define one of the deadliest complications of fibrotic lung disease. Another showed that even the most logical ICU intervention doesn't always improve patient outcomes. And the last encouraged us to take a fresh look at a treatment we've relied on for decades. That's why we read the literature, not simply to collect new facts, but to sharpen our clinical judgment. Thank you for joining me for another episode of This Week in Pulmonary and Critical Care Medicine. If you enjoyed today's episode, consider sharing it with a colleague, fellow, or resident. And if there's a paper you'd like featured in a future episode, let me know. Until next week, stay curious, stay humble, and keep bringing the best evidence to every patient you care for.